Yeah, I think we need to move on to the next talk, the last talk of today. I think is last but not least, we want to talk about will be on PIPAC. We want to introduce Professor Marc Reymond, who is the professor of surgery from University of Tübingen from Germany. I think many of you know that he's the one who is the pioneer of the PIPAC procedure. And he also a Secretary General for the ISSPP, the International Society of the Study on Pleural and Peritoneum. Okay, I'll pass the time to you, Marc.
Thank you, Jimmy. I will try to open the I cannot open, sorry. You hear me?
Yes. Yeah. And we see.
Can you share the screen?
I cannot share. I'm not allowed to.
And maybe Olivia need to unshare.
Yeah, I unshared, I think.
Yeah,
Okay, can you try now?
Now it's working.
Thank you. Yep, we see it.
Very good. So thank you for the invitation. It's a pleasure to be with you, and also a pleasure to see the high interest raised by these ISSPP webinar. So my topic is to tell you about the evidence on PIPAC. So first, as the inventor of the technology, I have a disclosure to make, or a few of them. And the second disclosure is that I performed the first PIPAC almost 10 years ago with my friend Marc Reymond, who is also here and in Bielefeld. And we are now 10 years later. And I would like to ask and try to answer 7 short questions. The first one is, what is today the level of evidence of PIPAC in peritoneal metastasis of gastric cancer? I will abbreviate PMGC. Second, what is the place of PIPAC in the upfront situation? Third, what is the place of PIPAC in the salvage situation, meaning second or third line? Fourth question, does PIPAC enable individualized therapy in this indication? Fifth question, could PIPAC be a cost-effective treatment? Then has PIPAC a role as a neoadjuvant therapy? And last but not least, could PIPAC be curative or help multimodal schemata to be curative in peritoneal metastasis of gastric origin? So the first question is, what is the level of evidence? So I used the Oxford levels of evidence in the version, last version, from 2011. I suppose you know this level of evidence. So as of today, there are 11 published studies or presented studies in major congresses. And to make it short, PIPAC with cisplatin and doxorubicin has reached an evidence level 3 in the upfront situation and only a level 4 in the salvage situation. If we now have a look at the recruiting and planned studies on PIPAC in gastric cancer, there are 7 studies. And for the first time, there are 2 randomized studies which are highlighted in green on this slide. And 2 are in the adjuvant situation, meaning cytoreductory respective gastrectomy and PIPAC, which is pretty new. And if we look at what we know about these studies, the first study shortly presented by Clarisse Evenot before in this webinar is expect to reach an evidence level 2 and to deliver the results in 2024, the earliest. And in the adjuvant situation, the randomized trial from Russia is expected to reach an evidence level 1B in 2029. So it's gonna to be a few years before we can say that PIPAC is an evidence-based therapy. However, we already have a bunch of data. And first, about the data in the upfront situation. So I have to talk about the best evidence, and the best evidence is from a prospective cohort from Moscow, Russia, under the lead of Vladimir Komyakov. I think he is participating to this webinar. So they treated 95 consecutive patients with PIPAC. Some of them received systemic chemotherapy alone, and others received systemic chemotherapy plus PIPAC with cisplatin. Which is interesting is that the decision to receive the one or the other treatment was not a medical or patient decision. This was just depending on the availability of the device in Russia, which was difficult because of the approval in Russia of the device by the authority, which was not available. So there were, as you see here, a majority of patients in the combined group. If you look at the risk profile, it looks like the group who received PIPAC was a little bit worse than the group receiving some chemotherapy. So to try to get rid of these differences in the groups, we asked our Institute for Biometry at the University of Tübingen to look at the data and to calculate the outcome using a propensity score, which is basically attributing an individual risk score to each patient before therapy. I went to Moscow, I had a look on the data, and the histology were reviewed by an independent pathology. The results are impressive. You see that in the systemic group alone, median survival was 7 months, and in the combined group, 14 months. And since the combined group had a worse profile, if you look at the adjusted hazard ratio for death after inclusion of the propensity score, you have a risk of death of 39.6% after combined therapy. And the second important information from this prospective cohort is that in the systemic chemotherapy, all patients were dead after 2 years. But in the PIPAC group, as you see, there were survivors after 2 years. The systemic chemotherapy was paclitaxel, ramucirumab, or irinotecan. Now, these surprising and promising data have been confirmed in the meantime by 2 other studies. The first one from the Charité Berlin, Beate Rau, presented by Andreas Brandl at the German Surgical Congress last year, is a case control study with a historical control just before introduction of PIPAC. And you see that here the median survival in the combined group reached 17 months versus 7 months in the systemic chemotherapy alone group. And as already mentioned before, the Lyon prospective consecutive registry data show median survival after PIPAC and systemic chemotherapy in patients which were no candidates for cytoreduced HIPEC, meaning with a PCI over of 7 and more. So it's a negative selection of patients reach a median survival of 19 months. Next question is, what is the place of PIPAC in the salvage situation? I remember here level of evidence 4. So we have in fact 3 sources. What we can say that the median survival is around 4 to 7 months, and that we have a high rate of objective histological response, and we have a low rate of PIPAC-related mortality, which is 0, and also the CTCI complication grade 3 and more were exceptional. And in both studies where this was assessed, the quality of life was preserved. This is an impressive example that has been published, that we published last year, where you see a patient with a signature pressure metastasis of a gastric cancer. You see before first PIPAC ascites, peritoneal mets and retraction of the mesenterium. After the first PIPAC, you don't see ascites anymore. You see a regression of the peritoneal mets, and after 2 PIPAC, the patient has a complete radiological response, and this is without systemic chemotherapy. That's the best case of the series, but for those used to treat that kind of patient, you will recognize that's pretty impressive. Next question, which is, I think, under-evaluated when we are talking now about different therapeutic modalities in this disease. What is the place of PIPAC for individualized therapy? So, sorry, I remember you a few things. Everybody knows the Lauren classification, and everybody knows that signaturing histology is linked to poor prognosis and has a frequent progression of the primary tumor to peritoneal metastasis. Perhaps you know that in the meantime, 4 molecular subtypes have been defined based on several genomic characteristics. It's now very clear that gastric cancer harbors many redundant oncologic pathways. There are small subset of tumors driven by the different pathway. Good example would be hair Neu with about 12 to 15% of patient positive. And this is indeed an obstacle for applying targeted therapies in gastric cancer. Now, if we now go into the specifics of peritoneal mets, what do we see? We see that the mutational profiles of the peritoneal metastasis differ from the primary tumor, and that several genomic characteristics have been related to aggressive gastric cancer phenotypes. Outstanding publication of the group of Wang in Gut last year. I recommend you to read that. Basically, they identified 2 molecular subtypes predicting treatment response. The first one, an epithelial subtype with 71% response to systemic chemotherapy. And I don't have to tell you that it looks pretty like the intestinal time according to the Lauren classification. And the second group, mesenchymal subtype, which is a little bit like the diffuse type in the conventional classification, only 1/3 response to systemic chemotherapy, but several expression of several targets that could be used for immunotherapy. So in practice, what are we doing at the National Center for Pleura and Peritoneum at the University of Tübingen? So our molecular board asked for a complete coding sequence of CDH1 and SMAD4 and the hotspots regions of a series of, let's say, usual suspects. I think very important is PIK3 and also ERP, which is equivalent to hair Neu indeed. Which is self-evident is to say that to do that, you need a biopsy, and to get the biopsy, you need a laparoscopy. So that's the first reason to make laparoscopy in these patients. There is a second reason, namely that the radiological criteria, according to RECIST 1.1, are difficult to apply. For example, ascites is explicitly excluded from the RECIST criteria. And by using a tissue biopsy, it is possible to determine an objective histological regression. And here I refer to the work of Wibke Solas and a group of 8 European pathologists from France, Denmark, Switzerland, Germany, I forget a few, and who are working together to validate this score. This score is already used in most PIPAC studies and might be used also to assess tumor response after neoadjuvant therapy when we do staging laparoscopy for deciding about the therapeutic modality. The next step is to look not at the histological regression, but the gene expression under therapy. PIPAC is repeated like palliative chemotherapy, but in sharp contrast to HIPAC, which is usually given only once. And on the example, well, the proof of principle that this approach might be used to refine individual treatment and prognostic estimation has been delivered in 2016 in ovarian cancer, not yet in gastric cancer, but this is the third reason to integrate laparoscopy and biopsy into therapeutic algorithms. So if now we try to summarize that what we are doing in Tübingen, so when the patient comes with gastric cancer and we want to operate on him, we make a staging laparoscopy, and then if the patient has a peritoneal metastasis, we treat him already with PIPAC, and indeed we take biopsy, which allow us to profile the tumor. The patient then receives neoadjuvant chemotherapy. Then we look again, assessing the tumor response. If the response is good, meaning the tumor is chemosensitive, then we believe that the patient is a good candidate for cytoreduction and HIPAC. If not, we adapt the chemotherapy depending on first the profile and second the response to the neoadjuvant therapy, which is usually flat in our institution, and so on. Okay, and this allows us to make let's say a stepwise selection of patient based both on theoretical assumptions, meaning mutational profile, but also on practical observation of the real effective therapy response or not in this particular patient. Fifth question, could PIPAC be a cost-effective treatment? The answer is probably yes, as I will show to you. So a group from the University of Vancouver and of UK cost effective specialists. You know that in UK they are very strong because of the NHS and the very structured healthcare. So they assessed the cost effectiveness of the intervention at two levels of care. The first one in the upfront situation and the second one in the salvage situation. These are the source of data. Basically, they looked at all the literature available, and then they did an order of magnitude of 100 simulations on the various modification of these outcomes using a Markov model. So if you take the summary of this simulation in the upfront simulation, this is the survival curve that predict for first-line chemo alone versus PIPAC and chemo alone, PIPAC plus chemo in the upfront situation. And the second curve is the survival predicted for a PIPAC alone versus second line chemotherapy alone. In both situations, you see that the patients survive longer when they received PIPAC. Now, if you will look at the upfront situation, so perhaps I have to explain the graph on the left. So the two dimensions are the cost and the additional quality. So you see that in this particular case, you have an additional quality, but you also have additional cost. And there is a cutoff here, which you can change. But if you take a cutoff at 30,000 pounds willingness to pay, then the combination of PIPAC with systemic chemotherapy is cost effective in about 1/3 of the simulations. Now, if you look at the salvage situation where PIPAC is alone, then indeed it's cheaper, and there is also a positive effect on quality, meaning that PIPAC CD was a dominant strategy. In other words, it was less costly but more effective than the comparator. This data has been presented at ASCO GI in 2020 and just have been refused by Annals of Surgery because PIPAC is not yet in use in the US. Question 6, has PIPAC a role as a neoadjuvant therapy in gastric cancer? So the answer is short, yes. If you look at the studies having evaluated this therapeutic indication, all of them describe conversion from non-resectable peritoneal metastasis to resectable peritoneal metastasis, with a range between 3.5% in the Italian group to 14% in the French group, and the German, both in Leipzig and our group in Tübingen, are at 8%. So in, let's say, a little bit less than 10%, it appears that you can convert non-resectable peritoneal metastasis to curative cases benefiting of cytoreductive surgery and HIPAC. And this brings us to the last question: could PIPAC be curative in this indication? So the answer is, well, is double. So the first one is, if you look at the French cohort and the Russian cohorts, in both cohorts, you see that about a little bit less than a quarter of the patients are still alive after 2 years, which is not described after systemic chemotherapy. So there is at least a hope that that there are long-term survivors in non-resectable peritoneal metastasis of gastric cancer after combined therapy, multimodal therapy, including PIPAC, but also systemic chemotherapy, and almost in all of them also secondary cytoreductive surgery, or yes. From our personal experience, I can tell you that yes, we have the first patients surviving up to 7 years after multimodal therapy, including PIPAC CD for non-resectable peritoneal metastasis after of gastric cancer. So probably these are the good cases if you look at the tumor profiling. And the challenge now for us for the future is to work together with the medical oncologists, with the translational researchers, to define which patient will benefit of which therapy. So now summarize. First, level of evidence. PIPAC does not deliver an evidence level better than 3 in the peritoneal metastasis of gastric cancer, and we don't have randomized data yet. So in the upfront situation, well, PIPAC CD is feasible, it's safe, doesn't impair quality of life, and survival data are encouraging. We have in this indication the first comparative data using a propensity score, so we can well, in fact, it's an evidence level 3, and a phase 2 RCT is recruiting, randomized, and this will deliver a level of evidence 2B in 2024. Sorry, the slide is not in the right sequence. Third, adjuvant situation. Associating PIPAC with gastrectomy is not recommended at the present point of time because of the risk of anatomic leakage. However, at least 3 centers are evaluating this approach under study conditions, and a phase 3 trial with 300 patients has started recruiting patients in St. Petersburg and Moscow, and we expect the results in several years. Salvage situation, PIPAC CD is feasible in the majority, but not all the patients. The patient after cytoreductive and HIPAC are the worst candidates. PIPAC does not impair quality of life. PIPAC induce an objective histological regression. The majority of the patient survival data are encouraging, but comparative data are not yet available. Cost effectiveness. Well, it looks like that PIPAC might be cost-effective in a proportion of patients in the upfront situation, and it might be that PIPAC would be cost-effective and more effective than systemic chemotherapy in the salvage situation. But once again, this is not demonstrated by randomized data. Neoadjuvant indication, it looks like that PIPAC could convert a little bit less than 10% non-resectable peritoneal metastasis of gastric cancer into a resectable disease, and there are long-term survivors in patients with unresectable peritoneal metastasis of gastric cancer after combined therapy, including PIPAC CD. This is a fact, but it's a fact that is repeats independently in several centers worldwide. So probably this is true. Yes, it is possible to cure a small proportion of patients from a disease that was assumed so far to be always lethal. So how we will do that? So as Jimmy kindly said, I'm the Secretary General of the ISSPP. ISSPP is a non-profit organization aiming at the continuous improvement of therapy of disease of the pleura, the peritoneum, and other serosa disease. So the promotion of research, innovation, further training and education, patient care, and interprofessional dialogue. It's, I think, a well-structured society. You had today an example which was perhaps technically not truly perfect, but of an initiative to bring the people together, not only the HIPAC surgeon or the surgeons, but also the medical oncologist and translational researcher on this topic, because we believe that's the only way to go forward is to talk together. Thank you very much for your attention.
Thank you, Mark, for the wonderful lecture and provide a very evidence-based approach to on this topic.